Okay. So when we suspect that the woman is in labor, how to take history? Or for diagnosis of labor, we have to take a proper history and do proper examination, right? So what when we take history, we have to take the detail of pain abdomen. If she is in labor, the pain should be progressive, and intensity should increase and frequency should increase. Okay, so you have to take history about how long she is having pain abdomen, duration, where is the site of pain. The site of labor pain is in the lower abdomen and radiating towards the back. Okay, and intensity should increase gradually, and the nature, it is intermittent. Okay, it comes and it goes, it is not continuous, and intensity is severe, very severe. Okay, it is a type of very, very severe pain, it's not mild pain. It is, and the intensity goes on increasing. There is blood stain discharge per vagina, and it is mucoid, blood mixed mucus discharge per vagina. This is also uh, told by the patient, and you have to also ask the duration of blood stain discharge PV. And if she complains of watery discharge PV, it is not always necessary to have this. Okay, only when she has ruptured the membrane or ruptured the amniotic sac, she will complain of watery discharge PV. That is described as sudden gush or constant leaking of fluid, and you have to ask what color of fluid is that. Okay, and usually the watery discharge is it's a whitish color because of mix of barnix in the liquor. Okay, and you have to also confirm the gestational weight by asking LMP and adding 9 calendar months and plus 7 days. Okay, by Nigel's formula. And expected date of delivery also you have to calculate, and then you have to calculate the how many gestational weeks she is in. Okay, and you have to ask about fetal movement, whether it is normal, whether it is increased, decreased, or even when sometimes the patient will say that there is loss of fetal movement, when you have to suspect whether there is fetal death. And you have to ask about previous antenatal checkups, reports if available, whether she has been immunized with tetanus toxoid, and whether she has experienced any antenatal complications before this visit. Okay, and then you will take the details of obstetric history, the past pregnancies, which gravida she is, parity, details of previous pregnancies, deliveries, or abortions if she had any, and how many living issues she is having right now. Menstrual history, previous menstrual cycles, whether it is regular or not, everything you have to take here. And contraceptive use before this pregnancy. Past history, family history, and personal history you will take as usual. And you have to do physical examination. When the patient is in labor, she is in pain, you cannot do detailed examination as soon as she arrives. So for this, you have to do rapid general evaluation, including vital signs. You have to look at the pallor, icterus, pedal edema, and you have to quickly auscultate the chest and cardiovascular system. And you have to auscultate fetal heart rate immediately after contraction. This is rapid evaluation when the patient is in real pain. Okay, and you have to auscultate the fetal heart rate for a full minute, every 30 minutes during active phase and every 5 minutes during the second stage of labor. And normal range of fetal heart rate is 110 to 180 beats per minute. If it is less than 110, it is fetal bradycardia, and if it is more than 180, it is fetal tachycardia. So irregularity of fetal heartbeat or decreased rate or increased rate, all are signs of fetal distress. If the membranes have ruptured, then you should note the color of amniotic fluid. Okay, whether it is clear or whether it is meconium stain, because all this information we have to fill in the partograph also. Presence of thick meconium, which is greenish color, It is the possible sign of fetal distress, and there is need for close monitoring, and sometimes it will need quick delivery. So we are focusing on the abdominal examination and pelvic examination. Okay, which position we examine the mother? She should be in supine position with slightly flexed thighs and knees, and if possible, the bladder should be emptied. And you should expose the abdomen from GP sternum to symphysis pubis. Always stand on right side of the patient. And on inspection, you have to note the contour of the abdomen, linea nigra, stria gravidarum. You should note contraction, frequency, and duration. Any scar marks. It can be due to previous cesarean section, or it can be due to any other operation or accidents. Okay, and you should also note the venous prominences if there are any, and whether the flanks are full or not, right? And we go to obstetric grips or palpation after inspection. So we have to note the fundal height with ulnar border of left hand. I'm just summarizing these examination. Okay, you have been taught about this. With ulnar border of left hand, or you can measure with tape. Symphysiofundal height you can measure from pubis, symphysis pubis to the upper border of the fundus. Yeah, and you can also take the abdominal girth at the level of umbilicus if you have measuring tape. And you have to determine whether the fundal height corresponds with the gestational age or not. Okay? And this symphysiofundal height in centimeter corresponds to the weeks of gestation. And abdominal girth at the level of umbilicus in inches also corresponds with the gestational age. So we have to combine both to determine whether her gestation or fundal height is corresponding to gestational age or not. Sometimes it is less than the gestational age, sometimes it is more than the gestational age, and most of the time it corresponds. These are the Leopold's maneuver to determine the fetal lie, presentation, and engagement. Okay, fundal grip is the first maneuver. How do we do it? Placing both hands in each upper quadrant of the patient's abdomen to determine which fetal part lies in the uterine fundus. If it is a normal lie and presentation, the fetal buttock will be felt in the this fundal grip. Okay, second maneuver is known as lateral grip. Here we palpate with both hands in either umbilical regions. Okay, differentiating the fetal back or spine from limbs. At one side you will feel the fetal limbs, which are irregular knob-like structure, and at another side you will feel the fetal back as a convex smooth structure. Okay, so by doing lateral grip we will know the fetal lie, okay, and position. The third maneuver is known as the pollix grip or second pelvic grip. Okay, we do it before the first pelvic grip. Okay? This is suprapubic palpation with single right hand to ascertain fetal presentation and engagement. Okay, if it is head, normally you can feel the fetal head is palpable because it is hard and globular. You can differentiate from other parts of the fetus. Okay, first pelvic grip or fourth maneuver is done the last. Okay, here you will use both hands. Okay, remember that only this pollix grip is done with a single hand. All other grips are done with both hands. Okay, palpation of bilateral lower quadrants of the maternal pelvis with both hands to determine fetal presentation and engagement. Both these pelvic grips are meant for fetal presentation and engagement. Okay, all the grips are done with the examiner facing towards the patient's head end or face, except the first pelvic grip, which is done facing towards the patient's feet. That's why it is done at the last. Okay, all others are done facing towards the patient head end. Okay, and only this first pelvic grip you have to change your position to face towards the patient's feet. Okay, this is how it is done. This is the fundal grip to know the part of the fetus lying in the upper uterine segment. This is the lateral grip. You keep your hands on either side of the umbilicus to know where is the fetal back and where is the fetal limbs. Okay. This is second pelvic grip or third maneuver or pollix grip. This is done by single hand, right hand, just above the symphysis pubis. You grip it, okay, and you can feel the fetal head and whether it is engaged or not. Okay, and first pelvic grip is the last last maneuver, and this is done facing towards the patient's feet, and you palpate the lower pole of the uterus to know what is the presentation and whether it is engaged or not. Now, vaginal examination is necessary to confirm the onset of labor. And it will also start with inspection of vulva and vagina, whether it is normal or not. Sometimes there is a gross vulval swelling, and there can be unilateral swelling also. And you will also notice the passage of show, which is blood-stained mucoid discharge. And there may be frank bleeding in case of antepartum hemorrhage. You can also see the liquor if the membrane has ruptured and she is passing liquor, whether it is clear or whether it is meconium stain. After that, we will put on sterile gloves over our hand and then do digital examination of the vagina. You will swab with antiseptic solution from before to backwards. Okay, don't swab from anus to the introitus. It is always from the introitus to the anus. Okay, and then first you introduce your index finger and then middle finger to palpate the cervix. And you should notice the dilatation of the cervix, whether it is closed. If it is closed, she is not in labor, or if it is fingertip also, she is not in labor or early labor, or it can be in various stages. It can be 2 centimeter, 3 centimeter, or when it is fully dilated, it is 10 centimeter. Okay, and you also should notice the cervical effacement or shortening or thinning of the cervix that is expressed in terms of percentage of the normal 3 to 4 centimeter length. Okay, that we already discussed. Now, continuing on pelvic examination, you should also notice the state of the membrane. If it is intact, you can feel the back of the membrane. Okay, it feels like a balloon full with water. Okay, if it is intact. Okay, and if it is ruptured, you will not feel any membrane and you will directly feel the fetal part or fetal head. Okay, and you should also notice the presenting part of the fetus and its descent. Okay, station -3 to +3 in relation to the ischial spine, 0 station being in line with the ischial spine. We have already talked in detail about this. And you should also notice the caput. Caput is the swelling of the fetal head during its passage in the pelvis. Okay, molding is overlapping of scalp bones. Okay, that also you should notice if there is any caput or molding. Also determine the position of fetal head. Where is the occiput in relation to the quadrant of maternal pelvis? So 8 occiput position we already discussed. Okay, whether it is anterior, posterior, or left or right. A few things about true labor versus false labor, because it is very important. Okay. False labor is actually due to Braxton Hicks contraction, and true labor is due to true uterine contraction. Okay, what is the difference? This false labor pain occur at irregular intervals, or it can be continuous also. True labor pain occur at regular intervals that shorten with time. Intensity of false labor remains the same. True labor gradually increase in intensity. False labor is just felt as discomfort in lower abdomen. In true labor, it is in discomfort is in the back and lower abdomen. There is no cervical change, no cervical dilatation, no effacement in false labor, whereas in case of true labor, cervix dilates progressively. False labor is relieved by rest and medication. True labor is not usually relieved by medication, and even at rest, it will progress. Okay, this slide is very important. It is asked in your examination. How to assess the progress of labor? Okay, a one-time examination is not enough in labor, because labor is a dynamic process. It goes on progressing. So how to assess the progress of labor? By changes in cervical effacement and dilatation during the latent phase, And during active phase, the rate of cervical dilatation and fetal descent is assessed. Okay. During second stage, because the cervix is fully dilated and it cannot dilate further, so only progress in second stage is assessed by further fetal descent below the level of ischial spine. And the progress should be plotted on a partograph once active phase of labor starts, that is more than 4 centimeter or more. You do not plot in the partograph when she is in 2 or 3 centimeter dilated. Okay. This is the modified WHO partograph. This is already printed in the paper, and you only need to plot and fill the parts. Okay, this part and these segments can be variable in different partograph, but all these components should be present. Okay, so this part is for the identification of the patient. This part is for the fetal heart, recording of fetal heart rate. This is the main part of the partograph. Okay, this is for amniotic fluid and molding. If there is any, you have to note it down here. This part is, you can see the alert line and action line. Okay, 1 centimeter per hour. These segments are for time. Okay, one square is equal to 1 centimeter and 1 hour, right? From vertical, the centimeter, cervix and dilatation centimeter from 0 to 10, and this part is for the timing, right? And this same scale is also used for the descent of fetal head, or how much fetal head is palpable per abdomen. Okay, so 2/5, 3/5, 4/5, this same scale is used, right? So fetal head descent should go down and the cervical dilatation should go above, okay, because the 10 centimeter is above. Okay, alert line, action line will describe later. Okay, hours and time. And this is for contraction of the uterus for 10 minutes. Oxytocin, if it is given, you should note it down here, how many units is going. Drugs, if any, given. And this is for the maternal vitals, pulse, blood pressure. And this is for output of the urine and presence of albumin, etc. So this is the whole modified WHO partograph. Yeah, how to use it? The modified WHO partograph is very simple and easy to use. Plotting begins in the active phase when the cervix is 4 centimeter dilated. Okay, 4 centimeter or more. Okay, don't think that if it is 6 centimeter, we will not plot it. So 4 and more, we will plot it. Okay, first segment is for patient information. You have seen it in previous diagram. In the topmost part. So name, age, gravida, para, hospital number, date and time of admission and time of rupture membrane, everything recorded every half an hour in active phase of labor. So amniotic fluid, if it is the membrane is ruptured, you have to record the color of the amniotic fluid at every vaginal examination. So I will denote it by I when membranes are intact. Okay, membrane rupture, clear fluid is denoted by C. Meconium stain is M. Blood stain is B. Because you don't have time and you don't have space to record in full form, you will use the short form. If it is molding, if there is molding, you have to note the degree of molding. First degree is sutures are just opposed. Okay, so the parietal bones or frontal bones can be opposed. Okay, second degree is sutures are overlapped but reducible. Third degree molding is sutures are overlapped and not reducible. This is severe degree of molding. Okay. Cervical dilatation is assessed in every vaginal examination and marked with a cross in that graph. Okay. You have already seen the alert line and action line. Okay, alert line is the line which starts at 4 centimeter of cervical dilatation to the point of expected full dilatation at the rate of 1 centimeter per hour, because that is the minimum rate of dilatation of cervix in active labor. Action line is parallel and 4 hours to the right of the alert line. Okay. Fetal descent is assessed by abdominal palpation. That is part of the fetal head. Head is divided into 5 parts, and you have to notice how much is palpable above the symphysis pubis. It is recorded as a circle so that you will not be confused with cervical dilatation. Okay, cervical dilatation is plotted as a cross, and fetal descent, head descent is recorded as a circle. This has to be done at every vaginal examination. So this is again the abdominal palpation for fetal descent of fetal head. Okay, here this is the symphysis pubis. The whole of the head is above the symphysis pubis. Here you measure it actually by the fingers. Okay, if 4 fingers are palpable, 5 fingers of fetal head is palpable, you say that fetal head is not engaged, and 5/5 of head is palpable. Here you can adjust only 2 fingers above the symphysis pubis. Only 2/5 of head is palpable. Why it is important? Because it denotes that head is engaged when only 2/5 or less of the fetal head is palpable above the abdomen. Right. Recording in the partograph. First thing to note is the cervical dilatation, and then you record the actual time after that only, right? And contraction is noted as it is recorded every half an hour, and you have to note the number of contraction in 10 minutes and their duration in seconds, right? If it is less than 20 seconds, you will fill 1 square by the dots. If it is moderate contraction, that is the contraction is lasting from 20 to 40 seconds, you denote it by shading in oblique lines. 1 square is filled by. More than 40 seconds or severe contraction, strong contraction is denoted by filling the whole square in dark. So adequate contraction means 3 to 5 contraction in 10 minutes, right? So you have to fill the square according to the intensity or timing of the contraction. Okay. Sometimes one contraction is moderate and one contraction is strong. Okay. Sometimes all contractions are strong. Sometimes all contractions are mild. Okay. Oxytocin is record the amount of oxytocin per volume IV fluid in drops per minute every 30 minutes when it is used. Right. Any additional drugs given should be recorded. Okay. Like it can be antihypertensive drug, it can be antibiotics, like that. Pulse is record every 30 minutes and mark with a dot. Blood pressure record every 4 hours and mark with arrows. Okay, like the systolic is upwards and diastolic is arrow downwards. Temperature used to record every 2 hours or when necessary. Urine protein, acetone, and volume record every time urine is passed if possible. Okay, so this is the field partograph. Okay, here you can see, and the first plotting should always be in the alert line, not in the left side. Okay, so here you can see when this patient arrived, this is the cervical dilatation denoted by the cross. She was 4 centimeter dilated. Intral os was 4 centimeter dilated, and this is the time, 9 a.m. Okay, this is first hour. This is time. So first plotting was in the alert line. After that, after 4 hours, she was again. She should be again assessed. Okay. Here you can see she was fully dilated at 1 p.m. Okay. So she was. This was in the alert line. So this is the minimum dilatation. Okay. If the labor is very fast progressing, this plotting should be in the left side of the alert line. If it is slow, it goes towards the right side. And if it touches the action line, that means it has become too late and you have to deliver by cesarean section if it touches the action line. If it is in the alert line or in the left side of alert line, that means the labor is progressing very satisfactorily. This is the uterine contraction. You can see here she is having 4 strong contraction in 10 minutes. This is the plotting of fetal head in circle. Okay, so you can see here the fetal head was 3/5 palpable here, and it goes on descending here. When it was fully dilated, the fetal head was 0/5 palpable, right? This is the fetal heart rate, okay, around 140, or it is slightly up and down. And this is the maternal part, maternal systolic blood pressure, diastolic blood pressure, maternal pulse, urine passed, etc. And when she delivers, we write it here: spontaneous vaginal delivery at 1420, live female infant, weight 2.8 kg. Okay, this is the completed partograph to delivery. Okay, and here you can see the liquor color, clear throughout. Okay, there was no molding, nil molding. Okay, so you have to see the partograph, fill partograph when you are posted in Gyne, and you will understand. And after finishing this mechanism of labor and partograph, you have to practice these questions to have more understanding. Okay, so describe the cardinal movements of labor. You have to describe from this descent, flexion, engagement, and then internal rotation, crowning, extension, external rotation, restitution, external rotation, anterior shoulder, posterior shoulder, and delivery of fetal body. Okay. What are the causes of non-engagement of fetal head? I have shown you in one slide. And how would you differentiate true labor from false labor? This slide also I have shown you how to differentiate. Describe the clinical features of labor. What happens? Okay, she will have pain, she will have blood stain, mucus, or also known as show, or watery discharge per vagina. She will have uterine contraction. And when you do PV examination, she will have cervical dilatation, effacement, fetal descent, rupture of membrane. All these are clinical features of labor. Describe the obstetric grips and their importance. Okay, how many obstetric grips are there? 4 obstetric grips. Fundal height is not a grip. Okay, measurement of fundal height is different. So obstetric grip means fundal grip, lateral grips, and 2 pelvic grips. Okay, these are also known as Leopold's maneuver. And what is their importance? That is to know the fetal lie, fetal presentation, okay, and whether it is engaged or not, all these things. Okay, you have to practice these things before your examination, so that you can write properly in your written examination. Okay, don't make the habit of typing. Make the habit of writing with hand, because in your examination you have to write down with your hand. Okay, and more you practice, more spontaneous you can write, because all these questions are the sample questions. Okay, actually these are very frequently asked questions. Okay, so you revise the slides, you go through your book. In the book you will find many things, because you will be confused if I tell you many things. These are the must know areas I have emphasized. Okay, so go through your book of Datta, go through the chapter of mechanism of labor, and write down these questions. And if you have any questions, you can ask, or you can write down in your chat box. Okay, are there any questions, Sachin? Any questions?
Ma'am.
Yes.